Dr. Chitra, do we move on to the next, because we are running short of time? And so again, wonderful opportunity for me to introduce our next speaker, Dr. Hemalini Samant, who will be talking on Introduction to Oculomycena Gravis. She is an assistant professor at J&J Hospital, Mumbai, and director of Eye Associates at Mumbai, with a 16-year experience and a collection of some wonderful cases and a lot of experience in treating neuro-ophthalmology. Pleasure to have Dr. Hemalini here with us.
Thank you, Dr. Rohit, for the introduction. Am I audible?
Yeah,
okay.
You are. Yes.
Thank you, Dr. Chitra, and AIOS team, as well as the ARC team for inviting me. Oculomycena gravis is a form of Mycenae gravis, and it commonly affects the extraocular muscles, the LPS, and the orbicularis oculi. And 50% of your ocular Mycenae gravis cases progress to a generalized Mycenae gravis. So I'm going to discuss a few take-home messages, keeping this presentation exactly 8 minutes. My first pearl is that Mycena is a great mimicker. So Oculomycena gravis may mimic almost anything from a third nerve palsy to a vertical gaze palsy to a superior oblique palsy. Let me show this interesting case to you, where I had a 24-year-old male. He came with complaints of sudden onset diplopia followed by ptosis, both progressively increasing. The general health was good. The ocular examination was normal, with particular attention to the pupils being normal. So this is what the patient looked like in the primary gaze. He had a ptosis with an exotropia. There was a mild adduction limitation. The upgaze seemed okay, but there was a defective, depression in abduction. And therefore, the diagnosis of an inferior division of the third nerve was made with a pupil sparing. And this patient was investigated elsewhere and then referred to me. So an MRI and MRI angio was done, and both of which were normal. So what next? So this is the primary gaze of the patient. A simple fatigue test in the OPD demonstrated that the ptosis had increased as compared to what we saw before. And then we did a neostigmine test in the OPD, which showed that the ptosis was absolutely normal and the squint had corrected itself. That clinched the diagnosis of a Mycena gravis. Hence, the pearl number one is that a Mycena gravis can be a great mimicker. And in a patient who presents with ptosis and or squint, Mycena should definitely form a part of your differential diagnosis. If the neuroimaging is normal, then you must do the receptor antibody test and in general, investigate the patient for a Mycena. Now, keeping this case in the background, let me discuss another case where this was a 30-year-old lady who came with the complaints of history of trauma with a bottle on the face about a month ago. And her current complaint was that her right eye looked smaller than the left. General health was good. The vision and the rest of the ocular examination was absolutely normal, except for the right-sided painless ptosis. Patient was reassured, and I asked her to follow up with me after 15 days to a month. And promptly, so this is what the ptosis looked like. There was a mild ptosis in the right eye, and the right eye looked a little smaller. The rest, everything was normal. 15 days later, when I saw the patient again, the ptosis was just the same. The patient had developed a face turn to the left, which I observed while taking the vision. And on examination, she, along with the ptosis, had a mild adduction limitation. So my observations were that this patient had a right-sided ptosis. The ptosis seemed variable, and I kind of imagined the lid to be flickering a little bit. There was a very subtle adduction limitation, and my differentials were, could this be a myasthenia? Should we neuroimage? Or should we do any other blood workup to rule out inflammatory causes? Now, I was a little biased towards myasthenia in this case, and hence went ahead and did the receptor antibody test, which was found to be negative. So what next? Then we decided to neuroimage this patient, and to our surprise, there was a large tumor, as you see in this picture. And so what the patient had was actually an evolving third nerve palsy. So the pearl number two is that any ptosis which worsens over time needs to be investigated. And if the receptor antibody test is negative, the patient must be neuroimaged. MRI would be the first choice for neuroimaging. Pearl number three, when does one suspect an ocular Mycena gravis? So if I come across an acquired ptosis with a normal pupil, think of myasthenia. If you come across an acquired ptosis with a dilated pupil, think of the third nerve. If you come across a ptosis with a constricted pupil, think of Horner's. But if you have any acquired ptosis where the pupil is involved, where the patient complains of eye pain, where there's headache, where there's an accompanying visual loss, where there's loss of the trigeminal nerve sensation, the Mycena gravis can be easily excluded. Pearl number 4. Mycenae gravis is not a disease restricted only to adults, but in fact can present in the pediatric age group as well. So this was a 5-year-old boy who came with complaints of sudden onset ptosis, which was progressively increasing. Variability was observed during the day, and ocular examination was normal except for the right-sided ptosis. So this is how the ptosis looked. We did a simple eyes test in the OPD. This is the post-eyes test. The ptosis had improved. That clinched the diagnosis of Mycenae gravis. The eyes test has certain limitations. It cannot be used in patients with strabismus in absence of a ptosis. And if you have to, then you have to document the improvement of the squint before and after with the use of prisms. The advantage is that it's a non-invasive test and it's a good alternate to the neurostigmine test and can be easily done in the OPD. This is another picture of a patient who had presented with a left-sided ptosis. We did a neurostigmine test for this child. This was done several years ago. I no longer do the neurostigmine test. And as you see in the picture that the ptosis had improved. Some of the relative eye signs in Oculomycena gravis are the Cogan's-Littwitz sign, the seesaw ptosis, and the peak sign, purely for academic reasons. And therefore, to summarize, the workup of a Mycenae gravis must include an eyes test, which can be done in the OPD. You have an option of performing the neurostigmine test, which has a sensitivity of almost 80%. I always send the patients for an RNS study and the single fiber EMG studies. The receptor antibody test should be done and is positive in about 50% of the cases with OMG. I always include a CT chest in all the patients to rule out the presence of a thymoma. And in some cases, myasthenia may coexist with other autoimmune conditions. And therefore, I sometimes ask for an ANA, a rheumatoid factor, and a baseline thyroid function test where relevant. So to summarize, the management of Oculomycena gravis, the role of myosin, which is an anticholine esterase, you start the myosin first and then supplement it with corticosteroids. And to non-responsive cases, you can then add in the immunosuppressants, plasma therapy. Thymectomy has to be done in cases of thymoma. The role of thymectomy in patients who do not have a thymus is controversial and debatable. Thank you.
Thank you, Dr. Hemalini. That was very nice. Shall we take some questions fast before we go to our last speaker, and we could indulge with more discussion after that?
Yeah, one question, ma'am, for Dr. Hemalini. What is your take on seronegative myasthenia gravis? How do you proceed in evaluating them?
So when I find that the patient is, negative for the receptor antibody test, I do order for the anti-musk antibodies. And if those are also negative, and sometimes when there's a strong clinical suspicion of a myasthenia gravis where the patient has presented with ptosis and strabismus, which is variable, sometimes after consulting the neurologist, we do empirically start a trial of myosin. And then if the patient does not improve, then then you start thinking of other things. You probably neuroimage the patient and refer it to the neurologist. I mean,
because the antibodies would be present only less than half of pure oculomycena patients. So you're right, Hema. You have to rely on, you have to give more credence to your clinical examination than the antibodies.
Are there any role of the newer antibodies, what they are claiming to, like the LRP antibodies, and there are a series of new antibodies which are coming up in the literature. Is there any role of that?
Yeah, so I haven't come across, Dr. Ambika, of any case where I've asked for this particular antibody, and I'm not sure if they are testing this in Bombay. Maybe some of the other people on the panel can throw some light on it.
Dr. Any experience, and when would you want to advise?
So the sensitivity of those newer antibodies for purely ocular myasthenia remains quite low. MuSK, LRP4, they can help to make the diagnosis with generalized myasthenia, but the data that I've seen at least would suggest that they don't have much of a marginal yield in pure ocular myasthenia.
So in these patients, I usually end up getting a single fiber EMG because I have a neuromuscular specialist who does it. And if you're doing the muscle that is actually involved in oculofacial myasthenia, the sensitivity is 98, 99%.
Single fiber EMG is fantastic if you have a good neuromuscular specialist who does them well. They're very useful.
But in children, it could be a little tricky with a single fiber EMG.
Yeah, I agree.